We're going to give it just a minute longer. Like I said, we'll get started at about 1:03. And we are here to discuss assertive community treatment and first episode psychosis, benefits through Nevada Medicaid. Okay, we've reached about 3 minutes after the hour to be cognizant of everybody's time. I will go ahead and turn it over to Lindsay and Chris Ann, who will be doing the presentation today. As we go through the presentation, if you have questions, you can go ahead and put those in the chat. We will have an opportunity for questions at the end. And then if we can answer them as we go in the chat, otherwise we will bring them up at the end. So Chris Ann, Lindsay, you're on.
Thank you, Lori. Hi. Good afternoon. My name is Chris Ann Taylor, and I'm a social service program specialist with Nevada Medicaid. Today, we're going to review the development of Nevada Medicaid's policy for assertive community treatment, or ACT. Please note that today's meeting is being recorded, and I put a link in the chat so you can get to the agenda and any of the policy documents for you too. So here's our game plan for today's workshop. First, I'll provide a summary of assertive community treatment. Then we'll review what an ACT team looks like, who is an ideal candidate, what services are included, and the proposed reimbursement model. Finally, we'll take a look at our implementation timeline, and we'll open it up for public comment and questions. Afterwards, I'll turn it over to Lindsay, one of my behavioral health teammates, to cover first episode psychosis policy, as well as other proposed updates to Chapter 400. So first of all, I'd like to extend our heartfelt gratitude to all of our stakeholders. Your collaboration and real-world perspective are essential to our success. We sincerely appreciate your unwavering dedication to the development of ACT in Nevada. So during the 2025 legislative session, assertive community treatment, or ACT, was included in the Medicaid budget. Because of this, Nevada Medicaid has been tasked with the development of policies and a reimbursement model for ACT services. So what is ACT? Assertive community treatment, or ACT, is a multidisciplinary, team-based, community-focused approach that is designed for individuals with serious and persistent mental illness. ACT is a service delivery model rather than a case management program. It offers comprehensive psychiatric treatment, rehabilitation, and support. Practitioners do not maintain individual caseloads. Instead, the team collectively ensures participants receive the necessary services to live in their communities. The ACT team convenes daily to discuss participant progress and adjust the services accordingly. ACT helps individuals remain in their communities while avoiding inpatient treatment. The team provides intensive wraparound services rather than referring participants to external providers. Services are available 24 hours a day, with most being delivered outside of a clinical setting. ACT team members meet participants where they are, whether they are at home, work, or any other community location where assistance is needed. So the average ACT team consists of 10 to 12 full-time staff members who deliver services to approximately 100 participants. ACT teams can start smaller with 5 or 6 team members and work towards the 10 to 12 full-time employees. There are 4 mandatory team members. They are the team leader, who serves as the administrative and clinical supervisor. Psychiatric prescribers manage the medication needs of all the participants. Registered nurses provide a wide range of treatment and support services with a psychiatric focus, and supportive employment and education specialists integrate vocal goals and services into the treatment plans. Now, depending on the number of ACT participants, the remaining members may contain a combination of the previously listed team members as well as the following: Substance use disorder treatment specialists are responsible for assessing and diagnosing substance use issues and co-occurring mental health conditions. Case managers typically hold a bachelor's degree and provide direct support by helping participants access healthcare and other social services. They are the central point of contact for all aspects of the participant's care. Finally is our peer support specialist. They provide a unique form of empathy and support that complements the clinical expertise of the other team members. They serve as a role model on self-help techniques, symptom management, and assist with creating community support systems. ACT targets individuals with serious mental illnesses like schizophrenia, bipolar disorder, PTSD, borderline personality disorder, co-occurring substance use and mental health disorders, OCD, panic disorders, or major depression. In addition to SMI, they have significant functional impairments and high utilization of emergency services, involvement with criminal justice system, housing or employment instability, difficulty living independently in their community, and they have been unsuccessful in traditional treatment models. ACT services are time unlimited and highly individualized to address the complex real-world problems that can hinder recovery. Core ACT services include crisis assessment and intervention, psychiatric care, comprehensive evaluation, individual supportive therapy, medication management, substance use treatment, supportive employment and education, referrals and linkages, family support intervention, illness management, as well as assistance with daily living, such as hygiene, nutrition, money management, and accessing community resources. ACT services are provided assertively, meaning team members go the extra mile to support and empower participants in achieving their goals. ACT provides in vivo interventions, which means services are primarily delivered within the community rather than a clinical setting. The goal is to help participants manage their symptoms, improve their quality of life, and integrate more within their community. So ACT is reimbursed using HCPCS code H0040, which carries a daily rate of $381. At this time, we're considering no prior authorization. And since the majority of ACT services are intended to be delivered in vivo or within the community, a place of service code will be required. The place of service code explains where the service was delivered. For example, at a shelter, in their home, at school, a park, or maybe at their place of employment. The ACT team will enroll under Provider Type 14, Specialty Group 814, as well as the new specialty number, which is still to be determined. Providers will automatically be linked to both of these specialties. Now, give me just a moment and I'll pull up the Medicaid Services Manual and show you where this policy is going to be located in Chapter 400. Can you see that all right? Yeah.
Yes.
Perfect, thank you. All right. So ACT policies begin in the Medicaid Services Manual at 403.6D. As you can see, the program description has changed from PACT, Program for Assertive Community Treatment, to just Assertive Community Treatment, or ACT. The eligible providers section explains the size and composition of the ACT team. The average ACT team maintains a minimum staff to participant ratio of 1 to 10. The team includes 4 required team members, with the remaining positions filled by a combination of the other allowable team members. The operational requirements section includes information on admission criteria, team meeting requirements, the overall service delivery model, and best practices. The eligible members section explains who qualifies for ACT services. Since ACT services are primarily for individuals with SMI or SMI with co-occurring conditions, who also struggle living independently and have other high service needs. The covered and non-covered services section lists all the services included or excluded from the ACT model. And then finally, we have the authorization, billing, and managed care sections. Now, please keep in mind that this is the first draft, very rough. We are in the very early stages of the development of the ACT services in Nevada. We fully expect future revisions based on both our stakeholder feedback and once we submit our state plan amendment or SPA to CMS, and those lovely discussions begin. So give me just a moment so I can return to my presentation. So here's what the implementation timeline looks like for ACT. It's going to require an MSM policy update, both a rates and program SPA or state plan amendment. It will also require a system change to create a new specialty type under provider type 14. The effective date for ACT services is July 1st, 2025. So we'll be applying these updates retroactively pending CMS approval. It's important to note that we are collaborating with the Division of Public and Behavioral Health to develop certification criteria for ACT, but this may take another year or so to finalize. So, thank you. This concludes my presentation, and now I will open this up for public comment or any questions in regards to ACT at this time. I don't see any. So Lindsay, you might be up.
Okay, sounds good. Thank you, Chrisanne.
Uh-huh.
Or I do see one question in the chat as well.
As far as the exact requirements, qualifications, that is definitely still something we're working out right now. But I'll add it to our list of questions, and then when we start getting some answers, we can let you know. Anyone else?
Philip has his hand raised.
Oh, there we go. Philip.
Hi there. Hello. Philip Ramirez from Molina. Just wondering if it sounds like the new specialty group number under provider type 14 has still not been established. Is that correct?
Correct. Yeah. No,
Okay.
we're still working that out.
Got it. So even though it's this ACT policy change is effective July 1 retrospectively, until there's that specialty number is established and providers are enrolled in that specialty. Is there anything for us to do at this point from an MCO perspective?
I don't believe so. Lori, you want to? I don't think there's much that can be done right now because we don't even have the specialty type. We don't even have a lot. I mean, a lot of the policy and even the reimbursement rules are still being worked out. So.
Correct. And this all will pend CMS approval as well.
Yeah. Yeah. Anything we're even saying today will pend with CMS.
Thank you very much.
No problem. And then I can't read your first other. Anna?
Hi, Anna Huntsberger, Washoe County HSA. So if there is no prior authorization required, would you see, and someone needs to have an SMI determination, would you see that perhaps they would just need to have like a yearly submission to Medicaid to say that they still meet the requirements under SMI just to remain eligible for the services?
At this time, there's no prior authorization. Now that could change between now and when it finally rolls out, but at this time, there wouldn't be any prior authorization required.
Okay, so it would just be
as long as they're enrolled in the provider type, 14 in the two specialties.
Mm-hmm. Okay. Right. Okay. Thank you.
Mm-hmm. No problem. Anyone else before we move on to first episode psychosis? No. All right, Lindsay, it's all you for now.
All right, I'll go ahead and share my screen. Thank you, Chrisanne. Okay, my screen should be pulled up. So I'll go ahead and get started. So hi, everyone. My name is Lindsay Bondyke, and I'm a program specialist with Nevada Medicaid within the Behavioral Health Benefits Coverage Unit. I am over outpatient and rehabilitative treatment services, and I will be the specialist for first episode psychosis. Thank you all for being here today. Today, I will discuss first episode psychosis and the service model of coordinated specialty care, which is used to treat first episode psychosis. I will go over the eligible providers, participants, covered and non-covered services, and reimbursement information for coordinated specialty care. I'll touch on the implementation pieces of this project, including a timeline. I will also review the policy itself, and there will be time for public comment at the end of my presentation. As a reminder, the slide deck is posted on the Medicaid Public Notices webpage for reference. To provide a brief background, first episode psychosis, or FEP, was added as a Medicaid budget line item in our most recent budget approval. Medicaid is now working to add the treatment of FEP to our policy and state plan. FEP is the early period after the onset of psychotic symptoms. These symptoms can include delusions, hallucinations, disorganized thoughts or speech, among others. The onset typically occurs between the ages of 15 and 45. First episode psychosis is what the individual experiences, and the service provided to treat FEP is coordinated specialty care. Coordinated specialty care, or CSC, is an evidence-based, recovery-oriented team approach to treating early psychosis that promotes easy access to care and shared decision-making among specialists, the person experiencing psychosis, and their family members. Coordinated specialty care utilizes a team approach, so each CSC team will have a board-certified psychiatrist as the team leader. The other eligible providers in the team include licensed professionals, qualified mental health professionals, peer support specialists, case managers, and supportive employment and education specialists. The eligible participants are individuals who experienced FEP within the last 18 months or experiencing early at-risk symptoms for psychosis. They are typically between the ages of 15 and 45 and have been identified by a professional as having a documented need for CSC. The proposed covered services for CSC include behavioral health assessments, individual therapy, group therapy, family education and support, supported employment and education, case management, peer support services, and crisis services. The non-covered services include non-evidence-based models, documentation, room and board expenditures, transportation, caregiver services, and supervision. The screening and introduction code that will be used is H2040. This service is allowed once per calendar year without a prior authorization. It is expected that this code will only be used once at the beginning of the participant's care. The screening and introduction bundled rate is $422.98, and this includes one assessment session, one initial diagnostic session, and one initial medication clinic. After the initial screening, CSC services will be paid based on a weekly bundled rate. The code used for the weekly services is H2041. This service does not require prior authorization. The weekly bundled rate is $244.96, and this includes 1 hour of psychotherapy, 1 hour of case management, 1 hour of peer support family education session with the client, and 1 hour of peer support.
Can you just speak up? Sure. Lisa Krasner just emailed me. She's going to come to help out.
If we could have everybody mute their microphones, that would be amazing. Thank you.
Thank you. The CSC team will enroll as provider type 14. We are developing a new specialty specific for the CSC team under provider type 14. The team must be enrolled as group number 814 and the specific specialty number that will be determined soon. Any individual provider that links to the group NPI will automatically be linked to both the group NPI and the specialty. The implementation pieces and timeline align with Assertive Community Treatment, which was discussed by Chris Ann in the last presentation. However, I will touch on these pieces again just to reiterate for FEP. We are adding policy to our Medicaid Service Manual, Chapter 400, Mental Health Services. We are also adding rate and policy information into our state plan amendments. Finally, as previously mentioned, we will be developing a specialty specific to FEP under provider type 14. In regard to the timeline, after today's workshop, a public hearing will be held September 30th, 2025, and these services will be retroactively effective as of July 1st, 2025, pending CMS approval. I will now pull up the policy to show you how it will be displayed in our MSM 400 chapter. CSC will be located in the Mental Health Therapeutic Intervention section within MSM 400, and this document is available for viewing on our public notices page. So I'll go ahead and stop sharing this screen and move over to the policy. 1 second, sorry. Okay, so now the policy should be pulled up. So I do want to make note that this policy is in draft form, and we are continuing to engage with stakeholders in the community to ensure that our policy aligns with evidence-based practices. For example, we have already made revisions to what you see posted here today based on feedback we have received, and we will continue to do so where needed. We have several follow-up meetings scheduled with providers in the coming days, so I want to say thank you in advance to those teams who are working closely with us as we develop this policy. I hope we can iron it out as much as we can before our final submission deadline. So with all that being said, I'm just going to give you a quick run through of what the policy is going to look like. This was all discussed in my presentation, so I won't get into too much detail, just want to show you an overview. So in these first 2 paragraphs, we give detailed information on what coordinated specialty care is and what is typically found in this service model. Moving down, we then discuss eligible providers, so all the team members that are part of this team, including the team leader, and we give descriptions of each provider type. And then scrolling down, moving on to our eligible members, so who would be eligible to receive these services. From there, moving into covered services, which this is also a piece that is in discussion as well of potentially adding more services here. Moving down into non-covered services, onto authorization requirements, billing information, which includes the 2 codes that I discussed, and then finally information for managed care members. So go ahead and stop sharing and pull back up my presentation. Okay. All right, so this concludes my presentation. I'll now open up for public comment and questions. Do we have any public comments at this time? Okay, I see one hand raised, I believe Trin.
Yes, good afternoon. Thank you so much for your presentation. So my name is Trending Mai, and I'm speaking on behalf of NAMI Nevada and NAMI Southern Nevada. And we want to thank the state for moving forward with funding the first episode Psychosis program. However, we are concerned that the proposed Medicaid bundle rate and policy do not align with the nationally recognized Navigate models, coordinated specialty care, with the exclusion of psychiatric care. We want to just state that psychiatry is essential to the success of the first episode Psychosis program. And without ongoing psychiatric care, medical oversight, and psychotherapy, multidisciplinary team support and participation in Project ECHO, the model loses fidelity, and this risks poor outcomes for young people experiencing psychosis that may even jeopardize our mental health block grant funding. So NAMI Nevada and NAMI Southern Nevada sees firsthand through our partnership with the UNLV's POWER program and participation in their coordinated specialty care group. When psychiatry and psychosocial supports are fully integrated, young people recover, relapse is reduced, and families are supported. And when these elements are missing, outcomes may decline. So we urge the Nevada Health Authority and Medicaid to revise the policy to fully align with the Navigate model by including psychiatry, psychotherapy, and team-based care. And doing so will protect both funding and the lives of Nevadans facing psychosis. Thank you.
Thank you very much for that comment. I know that's something that's been brought up elsewhere as well. So I have made note of that, and that's something I'm intending on discussing with our team to add before the final submission deadline. So I appreciate you bringing that up here as well.
We appreciate that. Thank you.
And then I believe the second hand I see is Dr. Fitzgerald.
Hi, Lindsay. Thank you.
Hello.
No, I think it's fantastic that, this is moving forward and we're getting this set up. I know that there's more in-depth feedback sessions on the policy. One fear that I have is surrounding the assessment piece and only being eligible 1 time per year. So if this is prior auth and a patient or a youth is assessed and does not qualify, maybe they're having symptoms that have not yet developed into a first episode, but 6 months down the road has developed, per our protocols, we would still have to reassess, do a full assessment, but yet would not be eligible for reimbursement under that model, despite them having not qualified. And so I think there's a question as to if somebody truly doesn't qualify, yet developed that first episode, but they've been referred, what would happen in the subsequent issue of being re-referred after development of a true first episode where they would still have to go through reassessment.
Okay, perfect. Thank you for bringing that up. I know prior authorizations have been something we've been discussing pretty heavily and trying to determine when or how often they should be used. So I'll definitely make note of that. This was something that was decided just in one of our most recent meetings. So I know we're still under a lot of revisions, especially when it comes to prior authorization. So that's good to note that it may need to be used more frequently than just the once per year. So thank you for that. Okay. And then do we have any other public comments at this time? Oh, and then Dr. Durrett.
Hey, thanks. I put a comment in the chat that resonates with the comment that Trin shared, and I appreciate you bringing that up. I have a lot of concern that the current proposed model, as we've talked
You're
about.
muted.
What? Can you not hear me?
I can hear you.
I can hear you. We can hear you. We
Okay.
can hear you.
Oh, okay. The current proposed model with the exclusion overtly of the role and the import of psychiatry really does place our patients at a deficit, given that these are extraordinarily vulnerable individuals coming at their first episode of psychosis. And with artful medication and all of the other services, we're going to be able to ideally help them have much more productive lives, such that they're not going to end up requiring long-term psychiatric disability and the like. So I wanted to bring that up. The other thing I was curious about was the funding structure, because as it lies, compared to how first episode psychosis programs at the two universities have been running, that it's going to put us at an enormous deficit, such as going to be quite a challenge to actually run these programs. The amount per patient per month that is not going to be covered is roughly $600 to $700 per patient per month. And when you multiply that over the 30 patients that are cared for by a center, it's going to be really a challenge to have a high fidelity treatment. And I'm curious to know if this is a fixed budget amount or if there are flexibilities.
So as far as I'm aware, this is a fixed budget amount, and Lori, feel free to correct me if I'm wrong. This was approved in our most recent Medicaid budget approval, so it is set what it's at right now. I know maybe in the future we could potentially talk about increases, but as of right now, I don't believe there's anything we can do as far as the rates go.
If that's correct. We had our fiscal was built on these rates with input from the Department of Public and Behavioral Health, who run the grants on the programs.
So I will say, and I think one of the things that will come up is SAMS has published several papers and research on a braided model, where most states that have bundled or Medicaid rates for FEP or coordinated specialty care, it accounts for anywhere between 25 to 40% of the cost of the program, with braided funding coming in. But I will say that, as Lisa's saying, that the 2023 estimates by SAMHSA put the Navigate model at about $1,700 per patient per month. And this is based on their research of programs nationwide. So I think that if rates are somewhat fixed, then advocacy for continued braided funding within how SAMHSA has modeled several other states, I think is going to be important towards success of bundled billing and keeping and allowing for CSC programs to exist.
Thank you for that. I appreciate that. I'm making note of this as you're talking. I think that is important for us to remember as we try to work through all of this. I know funds are always a very important piece when getting people services, so I appreciate you both bringing that up. And then do we have any other questions or comments at this time? Okay, I'm not seeing any more, so I'll go ahead. Just put up my last slide, just as my contact information, so you can feel free to reach out here if you have any further public comments that come up later on. I'll go ahead and stop sharing my screen. And then I do have one more presentation for everybody, so you're stuck with me for a little bit longer, but let me get that pulled up really quick. Okay, so my second slide deck should be showing, and I'll just jump right in. So once again, my name is Lindsay Bondyke, and I'm a program specialist here at Nevada Medicaid. I will now present on additional revisions we are making to Medicaid Services Manual Chapter 400, Mental Health Services. I will discuss 3 additional revisions to MSM Chapter 400. These 3 changes include limiting provider type 14300 to interns only, the removal of face-to-face references, and the removal of the intensity of services grid, leading to standardizing service limitations. There will be time for public comment at the end of my presentation. And once again, just as a reminder, this slide deck is posted on our Medicaid's public notice webpage. For the first change, we will be limiting provider type 14300, also known as qualified mental health professionals, to interns only. These interns include clinical social work interns, marriage and family therapist interns, and clinical professional counselor interns. The other fully licensed and certified professionals previously listed under this provider type will now enroll in the provider type that is specific to their specialty. There's an available provider type for each professional who could previously enroll as a QMHP, so there should be no issues with future enrollments. As an example, physicians will be directed to enroll under PT20 only moving forward. I wanted to make an additional note that QMHPs are listed as provider type 82300 as well. However, we are internally working on sunsetting provider type 82, so I did not want to include them in this presentation, but more information will come out regarding PT82 in the coming months, so please keep an eye out for web announcements regarding this future change. For the second change, we are removing all references to face-to-face throughout Chapter 400. As shown in this picture, we are simply removing the words face-to-face throughout the whole chapter. We have a separate MSM Chapter 3400 that is dedicated to telehealth services only. In 2023, Senate Bill 119 made revisions to Chapter 3400 to remove any limitations for the service delivery of behavioral health, allowing these services to be provided via telehealth. Therefore, the goal of this change is to align with MSM Chapter 3400 and keep that chapter as the sole authority for telehealth services to help limit confusion for providers. For the final change, we are removing the intensity of services grid located in MSM Section 403.5C. We are not removing the service criteria grid, which is located in MSM Section 403.5B. I included snippets from the chapter to show which grid will be removed and which grid will remain. So the grid on the left is the intensity of services grid, which we are removing, and the grid on the right is the service criteria grid, which will remain. The 4 services covered in the intensity of services grid include assessments, mental health therapies, medication management, and partial hospitalization programs. Rather than having the service limitations for these 4 services based on CASI or LOCUS scores, as they are in the grid, we are standardizing these limits, and I will show you how we are doing this for each service on the next few slides. For assessments, mental health therapies, and partial hospitalization programs, the service limitations will now be standardized and listed within the service grouping in MSM 400. I have displayed a snippet from our policy to show how the service limitations will be listed within the service grouping. As you can see, we describe what the general service limitations are rather than basing them on CASI or LOCUS scores. So for this example, all mental health therapies, including neurotherapy, will be now allowed for up to 18 units for adults and 26 units for children annually. As mentioned on the last slide, the limitations for neurotherapy have been standardized to match all other mental health therapy limitations. Neurotherapy service limitations were previously based on diagnostic codes, so I also wanted to make mention that these diagnostic codes limitations have been removed from policy, as you can see displayed here. For the 4th service listed in the grid, medication management, we have removed the definition from MSM 400 policy as this service functions under provider type specific to medical services. There will no longer be a service limitation or prior authorization requirement for the service. The goal of these changes is to standardize and hopefully simplify service limitations and prior authorization requirements. So this concludes my presentation. I'll now open up for public comment and questions. Do we have any public comments at this time? Okay, I'm not seeing any come through.
There's
Go ahead.
nothing in the chat, Lindsay.
Okay, perfect. Thank you. So this is the my contact information once again. So if anything does come up, please feel free to reach out if you have any public comments that you'd like to submit directly via email. But that concludes my presentation. So I'll go ahead and stop sharing. And I believe that is it for the public workshop today. So thank you all so much for attending, hearing us discuss about ACT, FEP, and a few more Medicaid Service Manual Chapter 400 revisions. We appreciate everybody's feedback.
Thank you.
Thank you all.
Mhm. Okay,
It's just us now.
cool. It's just us. Awesome.
Did you stop the
Perfect.
recording?
Oh, let me go ahead and do that.